So, today's topic is going to be about cardiac emergencies. What do you think about this heart? Any ideas? How you describe the LV function, the RV function, the atria, the valves? Anybody?
Okay. The LV looks dilated with akinetic apex,
yes,
and normal atrial size and normal RV function size. Normal size and function of the RV size.
Very good. So if you see here the lateral wall, and this is the inferior septum, and this is the apex. Mid-lateral wall is akinetic along with the apex. Mid-inferior septum is akinetic along with the apex. So it's only basal contraction, okay? There is only appreciable and tangible contraction at the base of the heart, okay? And this reminds you or ring any kind of diagnosis in your mind?
Be an anterior myocardial infarction.
Okay, anterior myocardial infarction, one diagnosis. Second possibility?
Takotsubo.
Exactly. But if you consider Takotsubo, I think you shouldn't stop at the diagnosis of Takotsubo. No matter what clinical and diagnostic data you have in hand, you still have to rule it out by coronary angiogram, right? Because the risk of missing myocardial infarction is really hefty. So you most likely Takotsubo or stress-induced cardiomyopathy so far is diagnosed retrospectively. After we do coronary angio and see the coronaries are normal, we find out that this is Takotsubo. Okay. Although there are some echo features we are going to discuss in depth later on, the echo features that is so suggestive of Takotsubo. There is MRI features, ECG feature, troponin, clinical data, all of which might suggest so much and strongly points to the diagnosis of Takotsubo rather than myocardial infarction. But still, the recommendation is to go for coronary angiogram, okay? Okay, so what are you seeing here? This is just to warm you up. Yeah.
Aneurysmal aneurysm with dissection flap.
Exactly. So there is a dissection flap. This is dissection type. Type A or B. Exactly. And what about the echo here?
This involving the root, type A.
Sorry?
It involves the root and the valve.
Which one? The second one here at the bottom.
Yeah.
Uh-huh.
In the bottom, the descending thoracic aorta. The dissection is the descending thoracic aorta.
Thank you so much, Yaraba. Yeah, this is a good observation, by the way. And mostly people tend to miss this dissection flap in the descending aorta. Dissection flap here might be well recognized and appreciated, but dissection flap in the descending aorta can be so missed, because we don't tend to look thoroughly at this black hole here. But this is and sometimes the dissection flap can be here and extending down to the descending aorta, or just involve the descending aorta. It's okay. And what about this case here?
The dissection flap involves the root and the valve. So it's type
A. And the valve, what's the problem with the valve?
Regurgitation, I think, would be.
Yes, because there is
malcoaptation.
Separation and malcoaptation, yeah, most likely this is going to be severe aortic regurgitation. There is dilated root. What else? What about the mitral valve?
The mitral valve myxomatous.
Myxomatous with flare prolapse of the posterior.
Speaking about Marfan disease.
Marfan, you are going to think about Marfan. Good. Great. Okay, so what is the definition of emergency? Medical emergency. Emergency is a condition requiring immediate and timely intervention to prevent death or disability. Okay, of course, there are so many definitions, but they are all pointing to the same kind of meaning. So you need an immediate and timely intervention to avert death or disability. So what's the difference between emergency care and critical care? Emergency care is the first encounter. Critical care is the ongoing care afterwards. So if a case of, let's say, heart failure, decompensated, came in pulmonary edema, the initial care established as emergency room, and then the patient will go for critical care for a few days before discharge. Okay, so emergency care and critical care both deals with serious condition. It's just about which comes first and next. Okay. Now, of course, back to basics, we have the past history is important. A patient of a history of heart failure, a patient of a history of ischemic heart disease, a patient of a history of metallic valve, or these are so important clinical data. And the presenting complaint, how the patient presents, complaining of what? Then the clinical exam. Okay, the blood pressure, the heart rate, the level of perfusion, the level of congestion, and the murmurs. Okay, then we have the preliminary diagnostic tools we have probably in all cardiac centers and even in secondary hospitals. We have the ECG, the chest X-ray, the biomarkers, and the echo. And of course, there is an advanced kind of investigative panel that can proceed further, upon which you could proceed further. But most likely, by the way, upon past history presenting complaint and clinical exam, you would be able to formulate a differential diagnosis, upon which you are going to tailor a diagnostic workup. Okay, that's what you always do day in and day out. Now, what are the emergencies we have? Emergencies, what do we have? Cardiac emergencies we have. By far and away the most common is the acute coronary syndrome. You agree with me? انتوا دي أكتر حاجة انتوا قاعد تمر عليكم، صح؟ Acute coronary syndrome. صحيح؟
Yes.
Exactly. Then heart failure, either new or decompensated heart failure, arrhythmias, fibrillation and blocks, most two commons, pericarditis, myopericarditis, and precardial effusion, relatively uncommon. Probably there is a resurgence of pericarditis, myopericarditis of late because of COVID infection. But before COVID, we rarely encounter myopericarditis and myocarditis and stuff like that. But with COVID, and I think you also in Sudan, you are seeing more cases than before of pericarditis and myopericarditis. Okay, now valve disease. Valve disease, they don't come as emergency as valve disease, but by inducing or inciting decompensated heart failure. Okay, and pulmonary edema, whatever the cause is. We have also hypertensive emergency. We have acute aortic syndrome. And by acute aortic syndrome, we mean dissection, ulceration, and hematoma. Okay, the three types of acute aortic syndrome. Pulmonary embolism is usually dealt with by our colleagues in pulmonology, but sometimes we share workup with them basically in echo and stuff like that. So we have to know what they are looking for in terms of echo and ECG and biomarkers. Okay. Now, this is a 41-year-old gentleman with chest pain, and this is the ECG. Looking at the ECG, what are you expecting he is going to be presenting with? What are the characteristics of chest pain of this patient? So this is a typical ECG of what?
Pericarditis.
Pericarditis, because we have concave ST segment elevation, we have PR depression, we have PR elevation and AVR. Okay, so this is typical ECG of pericarditis. So what are the characteristic features of chest pain in this patient? His chest pain is going to be positional, relating to respiration, improves on leaning forwards and worsens on lying flat, right? Okay, and it is stabbing sharp. You might elicit pericardial rub. Okay. What other history data has bearing on the management in this patient? Are you going to ask any further questions about the history in this patient that might be pertinent to the plan of management? Of course, you are going to ask about what points to the etiology, right? So if there is an antecedent viral infection, vaccination, okay, trauma, autoimmune connective tissue diseases, right? Renal failure. These are all history data, which is important. Bleeding tendency, okay? What lab and imaging data would you like to obtain? Lab data. Of course, the regular routine one, CBC and UNE and stuff like that is okay. But what is specific lab test you are gonna ask for in this patient?
I would like to ask about ESR serum, CRP, but the indication of admission is myopericarditis, which is indicated by high serum troponin.
Very good, Yazin. Thank you so much. So troponin is important because troponin is going to shift the diagnosis from pure pericarditis to myopericarditis, okay, or pericardiomyositis, okay? So meaning the inflammation has extended to the muscle, and that's important, okay? It's more prognostic to have perimyocarditis or myopericarditis than to have pure pericarditis. So troponin is important. What imaging data would you like to obtain? If any, you can tell me. I don't need any.
Echocardiography may show bright pericardium, pericardial effusion, and
thank you so much, Yazina. Yes, exactly. Yani you are gonna order echo just to rule out pericardial effusion, because sometimes you can have pericarditis and there might be moderate to large pericardial effusion. So in this kind of patient, you need to keep them in hospital or keep an eye on these patients closely and follow them closely by echo and clinical evaluation. So it's important to do echo. Now, Zainab said you will find an echo dense pericardium. Yes, you might see that, but most likely you are not gonna see that. So the pericardium is gonna look normal in echo. You might see a trace pericardial effusion in around 60% of cases of pericarditis, but otherwise the texture of the pericardium will most likely look normal. Okay, but if in doubtful cases, and if you want to establish the diagnosis beyond any reasonable doubt, what kind of imaging tool would you like to ask for to confirm the diagnosis of pericarditis?
CT.
I want to add.
CT. Any other suggestion or opinion?
I want to add a point. Here in Sudan, we have to think about tuberculosis in every case. So I want to do also chest X-ray to rule out tuberculosis, pericarditis that can be seen with calcified or calcification lesion. Yes.
Thank you, Sam, for reminding us. Yes, of course, we have to consider our geography, and that TB is still not uncommon, so it has to be borne in mind, and you have to gear your clinical evaluation and your diagnostics accordingly. Okay, so chest X-ray might show features in the clinical history, you might elicit features and all of that. So this is really important. Yeah. And of course, the pericardium of tuberculous pericarditis tends to be thick, fibrotic, and calcified. So you could see that even in the chest X-ray, you can see it in the echo, and of course you can see it much better in cardiac CT. Back to my question: what is the best imaging tool by which you can confirm the diagnosis of pericarditis, i.e., inflamed pericardium?
CMR.
Maybe CMR.
Exactly. MRI. MRI can show the inflamed pericardium. Exactly. Okay. So what are the indications for admission? Are you going to admit all patients of pericarditis? Are you?
Maybe features suggestive cardiac tamponade in the top.
Okay, so not all patients. So what other type of patients you are going to admit? If there is fever, you better admit this patient. Okay. If it is subacute onset, something that has been lingering on for some time, you better admit this patient. If there is elevated troponin, if there is history of trauma, if patient on anticoagulation, if patient is immunocompromised, if it is non-idiopathic pericarditis, non-idiopathic, okay, something like relating to connective tissue disease, to renal failure, to stuff like that, meaning that's a different and less of a benign condition, right? When it is relating to connective tissue disease, or when it's relating to renal failure, meaning these patient has to be kept in hospital for further evaluation, right? So these are indications for admission. Of course, there is a scoring system nowadays, okay, that encompasses all the clinical data, the ECG data, the echo data, and further imaging data and biomarkers, and you can have certain scores upon which you admit and upon which you discharge. Okay. What are the discharge medication? So if a patient of pericarditis, otherwise things are fine, you are going to discharge this patient on non-steroidal anti-inflammatory, right?
Like ibuprofen or indomethacin.
Exactly.
Or colchicine, the other option.
Will you give a steroid?
Yes. If it tuberculosis, this is one of indication of using steroid.
For all patients?
No,
Uh-huh.
for tuberculosis patient.
Okay.
So the discharge medication according or tailored according to the cause of the pericarditis.
Exactly. Exactly. So steroids, if it's not tuberculous, exactly, like you said, it's about the etiology. If the etiology of connective tissue disease or tuberculosis, steroids might come first. But otherwise, in idiopathic form of tuberculosis, of pericarditis, you don't give steroids. Okay, actually, you better avoid steroids because it might aggravate the condition somehow, unless it is sort of recurrent pericarditis or resistant pericarditis. So remember these two words, recurrent or resistant, or specific etiologies like we discussed. So the most common cause of pericarditis is by far and away idiopathic, by the way, followed by infection, uremia, acute myocardial infarction, which could be acute or delayed, okay? Neoplasm, post-cardiac injury syndrome, autoimmune disease, SLE, and all of that, okay? Now, this acute myocardial infarction, you can have it acute, you can have it delayed. Acute meaning within few days, usually 3 to 7 days, okay, after the myocardial infarction. And you will find that, by the way, this is a real dilemma. We have been confronted with these cases of pericarditis on top of myocardial infarction, and you get stuck of whether this chest pain is ischemic chest pain and you have to take the patient back to the cath lab, or it is pericarditis. So you have to focus clinically on the features and decide, okay? Echo might also be of help and all of that, but remember, the recurrent chest pain after myocardial infarction and after revascularization may be acute pericarditis. And this is, it tends to be regional on top of the injured myocardium. So the injured myocardium irritates the overlying pericardium, okay? It can be delayed, and when it's delayed, it tends to be global pericarditis, and it is sort of autoimmune syndrome that is called Dressler syndrome, weeks to months after myocardial infarction, okay? Now, what is post-cardiac injury syndrome? What is this? Have you ever heard of this, post-cardiac injury syndrome? Post-cardiac injury syndrome. We also call it post-cardiotomy syndrome. Post-cardiotomy syndrome. So after cardiac surgeries, okay, patient comes days to weeks after with chest pain, pericarditis, chest pain, okay? And you do their chest X-ray, you might find pericardial effusion, pleural effusion, and all of that, okay? So this is, in a way, it looks like Dressler syndrome, because when they open the chest and they manipulate the heart, sequester antigens from the myocardium is released in the circulation that might induce antibodies that might react with the, or cross-react with the pericardium, leading to inflammation and all of that. And it tends to be like polyserositis. So the pleura might be involved, the pericardium might be involved, the joints, patient might also be febrile. It's more of global systemic disease, okay? But my impression that it's relatively common. We have seen so many patients coming back after cardiac surgery with this syndrome. And it's just treated with non-steroidal anti-inflammatory drugs, okay? So these are the features of chest pain in myocardial infarction, in pericarditis, and in pleural, in pulmonary embolism. We're not going to elaborate on this. Now, if we go back to the ECG of pericarditis, as we said, it's concave global ST segment elevation with PR sagging and PR elevation here. But remember, we have stages. In stage 1, we have this concave then it tends to come back, and in stage 3, it becomes inverted. In stage 4, it's normalized, okay? And in all these stages, the patient might still have chest pain. So if the patient comes with chest pain and he's in stage 1, it's easy to diagnose. But if he comes in stage 2 and stage 3 and 4 with chest pain, then you get stuck because it's no longer typical ECG, okay? Now, what are we seeing here? What are we seeing here? This is an echo, and this is the corresponding ECG, or the ECG equivalent to what you are seeing in echo. So anybody can tell us?
Electrical alternance on the ECG.
Yes.
And
Exactly.
this is swinging, massive pericardial effusion is swinging heart.
Very good. Are they related?
Yes.
In what way?
The heart is come near and then away from the chest wall.
Exactly.
Giving the ECG features called electrical alternance.
That's great. Thank you so much. So sometimes we are in the exam and we ask our candidates whether this ECG means tamponade. What's your answer? Does this ECG, if I show you the ECG without the echo, will you interpret it as tamponade?
Yes.
Why?
Possibly. The tamponade, yes, tamponade creates an interventricular interdependence.
Okay.
In the echo, it is correlated with pulse wave in the mitral or tricuspid annulus, giving variation with inspiration.
Good. I will rephrase the question. What's the most common ECG feature of tamponade? Yes, just
I don't know what is the most common, but I think that this alternance, pulse of alternance, is not one of the features of cardiac tamponade.
Is not.
I don't think.
Okay.
Yes, biologic. Just
okay.
biologic.
Good. So
Tachycardia.
Tachycardia, low voltage ECG.
Yes, yes, yes. So it is tachycardia. Okay. Tachycardia correlates with tamponade because tamponade is a shock state. So you have to have something that indicates shock. Now, a low voltage or electrical alternance are indicators of large pericardial effusion. Period. You might say that the larger the pericardial effusion, the more likelihood of tamponade. I might accept that. But it does not indicate direct sign of tamponade. They are not direct sign of tamponade. They are signs of large pericardial effusion, both low voltage and electrical alternance. Okay. Now, for acute coronary syndrome, we know the 3 types: STEMI, non-STEMI, and unstable angina. And now, chronic coronary syndrome. So it is no longer called chronic ischemic heart disease, but chronic coronary syndrome. And it spans different phenotypes. Okay, we are going to discuss the chronic coronary syndrome separately. Okay, why they have changed the terminology from stable coronary artery disease, stable coronary artery disease, or ischemic heart disease to chronic coronary syndrome? Why? For 2 reasons. They want you to feel so much the relationship between acute coronary syndrome and chronic coronary syndrome, that they bear the same pathology. Okay, and they overlap really a lot. The other thing is that it is a syndrome, and syndrome means not so precise etiology and not so precise manifestation. So it has many etiologies and many manifestations. So the word syndrome is more meaningful than disease, okay? And here are just 5 phenotypes of chronic coronary syndrome, but we have more, okay? So chronic coronary syndrome has replaced the old terminology of chronic ischemic heart disease or chronic coronary syndrome. Stable coronary artery disease, okay? And like we said here, the normal pristine vessel is this one, then atheroma is start to accumulate, okay? We might go in a stage of overcompensation and aneurysmal dilatation. That's why in the cath lab, when you are confronted with ectatic vessel, that might be atheroma, okay? Atheroma induces ectasia by this extrinsic remodeling of the artery. But most likely the arteries goes in this direction or this direction. So there is gradual narrowing until it reaches a stage when symptoms appear. This tends to be kind of stable and chronic coronary syndrome. A biological accident might happen due to plaque rupture, fissure, or crack with acute thrombus formation and total or nearly total occlusion of the vessel, and that's acute coronary syndrome, okay? So the parent pathology is the same, okay? They just diverge into chronic coronary syndrome and acute coronary syndrome. Now, I want you to remember that intervention and revascularization is of tangible and robust outcome as far as acute coronary syndrome is concerned, but not so much so in chronic coronary syndrome. Again, intervention is important for acute coronary syndrome because it has impact on heart clinical outcomes. But the impact on heart clinical outcome was not well appreciated in revascularization of chronic coronary syndrome. Agree or disagree?
Yes, we agree.
Okay, great. Interventionists are still, skeptical about this. Now we have the Ischemia trial, okay? And Ischemia trial was a really courageous trial. It came in tandem with previous studies, which has evaluated medical therapy versus revascularization. But this one was larger, landmark trial, and it has chosen patients of moderate to large ischemia by non-invasive testing. Okay, so they have chosen serious patients. They only excluded left main, and then they put them in 2 arms, revascularization and medical therapy. Okay, and they found no difference in the heart clinical outcomes between medical therapy and revascularization plus medical therapy. Okay, so meaning revascularization has added nothing in the way of prognosis. Okay, this is ischemia trial. Okay, now there is the new trial, Revive BCIS2. This is published in 2022. You probably heard of this. Again, it is an important landmark trial, okay? In this one, they have chosen patient of ischemic cardiomyopathy with low ejection fraction. See, with low ejection fraction. And then they divide them in 2 arms, revascularization plus medical therapy or revascularization or medical therapy alone. لاحظوا هنا يختاروا منهم اختاروا في ischemia trial they have chosen patient of moderate to large ischemia by non-invasive testing. Now in Revive they have chosen patient of low ejection fraction due to ischemic cardiomyopathy, and they assign them to revascularization plus medical therapy versus medical therapy alone. And again, no difference. حتى no difference in the recovery of the ejection fraction over time. Very disappointing trial, صح؟
Yes.
طبعا انا دي بعتبرها يعني study كانت قاصمة الظهر للintervention in chronic crisis. اوكي يعني حتى البيشنت of low ejection fraction ما نفع معاهم الريفاسكولارايزيشن compared to medical therapy عنه. اوكي I don't know لكن انا بالمناسبة for quite some time I had this impression in so many patients of low ejection fraction due to ischemic cardiomyopathy, they did revascularization after revascularization. I didn't appreciate a robust impact on their ejection fraction. Yani from echo perspective, because I'm in echo lab, okay? For now, Revive has confirmed that ejection fraction did not differ between the two groups. Okay. Now, the chest pain analysis, how you are gonna analyze the chest pain, you have the clinical data, which is gonna get you to the pretest probability. Then the ECG and the biomarker, okay? That's the three tools upon which we work up the chest pain or analyze the chest pain. In the light of clinical data, ECG and biomarkers. Now, the features of chest pain and what is typical and what is not typical are here. You also, in the clinical data, it's important to probe into the characteristic of chest pain, the aggravating and relieving factor, and you elicit the risk factors, okay? You elicit the risk factor. Then upon the clinical data, okay, you will be able to put your patient into either mild risk, intermediate risk, or high risk. Okay, good. Now, in the new guidelines, they have changed the terminology of typical, atypical, non-cardiac into typical, possibly cardiac and non-cardiac, right? So they no longer use the word or the terminology atypical chest pain. نحن طبعا سابقا كان we use three features to characterize chest pain as typical, atypical, and non-cardiac. Okay, اللي هي central chest pain, heaviness in nature, relieved by rest, and induced by exertion, relieved by rest. So these are three. If you have 3 out of 3, this is typical. If you have 2 out of 3, this is atypical. If you have 0 to 1 out of 3, that is non-cardiac. Okay, so now the guidelines asks us for atypical chest pain, consider it possibly cardiac chest pain. Why is that? Do you have any idea why they have changed the terminology from atypical chest pain to possibly cardiac chest pain? عشان يعذبوني زيادة صح؟ فعلا هو الفكرة الأساسية عشان يعذبوك زيادة، بمعنى إنه هم لو لاحظتوا أنتوا in your practice, probably the vast majority of patients who comes with acute coronary syndrome or chronic coronary syndrome, a chest pain حقهم is not so typical, you know? It's not typical. يبقى the norm is atypical chest pain. بالتالي كلمة atypical دي لو أنت تصدرها للفيزيشن they feel إنه atypical is non-cardiac, it's close to non-cardiac. No, they want to elevate atypical to close to typical. لأنه the vast majority of ischemic heart disease present atypically. لأنه كلمة atypical export a negative connotation of إنه this is non-cardiac. That's why they made it possibly cardiac. عشان يعذبوك في الحتة دي. You focus more and more. Okay. طيب, now I have this patient, 85-year-old gentleman, no risk factor for RTDs, presented with static chest pain. Initial ECG and troponin were normal. So what's the best course of action? What are you going to do here? Reassurance, invasive coronary angiogram, non-invasive testing for ischemia.
This patient, low risk, age 35, and most likely positional chest pain, most likely pericarditis. So I will do for him simple investigation, echo, just echo.
Okay.
I suggest he.
Great. And after that, if things are okay, you're gonna
reassure him.
Exactly. Okay, because this is, as far as ischemia is concerned, this is low probability of ischemic heart disease. Okay. Now, what is this? 72-year-old gentleman, diabetic, hypertensive, had PCI to LAD 2 years ago, presented this occasion with chest pain, which is burning. Initial troponin and ECG were normal. So what is the best course of action here? Reassurance, angiogram, non-invasive testing for ischemia.
I think this patient has a high pretest probability and
Yes.
high clinical likelihood.
Exactly.
So I go for invasive coronary angiography directly.
Very good. Very good. By the way, I agree with you. Though if you have chosen non-invasive testing for ischemia, that wouldn't be wrong as well. يعني انت اذا افترضت انه هذا البيشنت يعني unstable angina, is it unstable angina? Maybe. If it's unstable angina, then you put him into acute coronary syndrome category, then coronary angiogram is the way to go. But if it is, yeah, we know that this is ischemic chest pain, but is it acute coronary syndrome or chronic coronary syndrome? If it is chronic coronary syndrome, why should I go for revascularization? I might go for the invasive testing for ischemia, and upon the result of which I might decide to go for cath if I elicit high burden of ischemia. And in this case, I will be violating the ischemia trial حتى لأن ischemia trial بقى لك حتى الناس اللي عندهم large burden of ischemia medical therapy is the way to go if you exclude left main. Okay. ولكن لحد الآن الجايد لاينز في انه في الكرونيك coronary syndrome, if there is good chance of revascularization, patient is still symptomatic despite optimal medical therapy, you can go for revascularization. Okay. Now, a 45-year-old lady, diabetic, presented with effort-induced stabbing chest pain. Her initial ECG and troponin were normal. So what are we going to do here? What are we going to do here?
For this patient, I will do for her my CT angiography.
Okay, great.
Non-invasive testing for ischemia. Then if suggestive, I will do invasive coronary angiography.
Very good. So, يعني يا زينب, you have categorized this patient as
low
mild, intermediate, or high risk?
Yes.
This
patient, moderate risk.
Exactly. So this is intermediate risk. Exactly.
Yes.
Mild risk, you don't have to do any further workup. High risk, you may go for cath right away on non-invasive testing. But intermediate, then you don't have the courage to discharge them and reassure them. The same time, you don't have the courage to send them for cath right away. Okay, so you have to have a relay station upon which you confirm your suspicions and doubts. And I think non-invasive testing is the best course of action. Okay, so do non-invasive testing. And here the non-invasive testing we have stress echo, we have PET, SPECT, we have PET, we have cardiac CT, and we have stress CMR as well. So we have 5. In addition to the exercise ECG, okay? But these are called imaging stress testing. They are 5, okay? So in Sudan, you have stress echo, you have SPECT, and you have cardiac CT. right? Right?
Yeah. Yes.
So PET is not available and stress CMR is not yet available, right?
Yes.
Exactly. Okay. يبقى معناته الآن from which of these 5 or which of these 5 you are going to choose for your patient? That depends on availability. يبقى whatever available you go for. طيب نحن عندنا في السودان قلنا stress echo and SPECT and CT. لو كلهم available, then you are going to consider the cost, the radiation, and stuff like that. Okay. What else? What other factor you are going to consider when choosing the modality of testing for ischemia?
According to availability and availability of expertise in analysis of the imaging.
Very right. You're so right. Exactly. يعني expertise is important جدا يا اخواننا. يعني مثلا تلاقي انه الناس في النيوكلير كارديولوجي are not as good as in cardiac CT. يبقى معناتها احسن لنا الكاردياك CT. اوكي. او عندنا مشاكل في الايكو كارديوغرافرز مثلا in السودان. So يعني الاكسبرتيز مهم له دور برضه. What other factors?
Comorbidities. Comorbidities.
Comorbidity.
Yes.
How is
Yes, if the patient, for example, CKD, I cannot give him contrast, and so I will go to image without contrast. If the patient atrial fibrillation, I cannot go for CMR and like that.
Thank you so much, Yassan. This is really right, and it's a good point. Yeah. So the renal failure or renal impairment, you are gonna avoid contrast, fast heart rate, and if you are probably gonna avoid coronary CT or cardiac CT. Yeah. Good. What else?
Obese patient, patient with arrhythmia, atrial fibrillation, we cannot control heart rate, cannot go for CT angiography.
Very
And
good, yes.
high calcification, also high calcium and calcification. This will interpret with result of the test. And echo, if there is patient have LBB or something like this, this will cause regionality or paradoxical wall motion abnormality, which interpret with test results.
Exactly. You're right. So thank you so much for this nice discussion. You have mentioned all things. Now, the last thing is the nature of the test itself. يعني الآن مثلا إذا افترضنا إنه my patient is not having any of the factors that makes me compelled to choose one over the other. And I have stress echo, I have SPECT, I have PET, and I have cardiac CT. Okay, with all available, all of good expertise. So which one I'm gonna choose? الناس فكرت وعملت studies في whether the modality of testing has any impact on the future outcome. There was a tendency that cardiac CT has the best impact on future outcome if it is chosen as non-invasive testing compared to the remainder. Okay. Do you think why? Why? Any idea? ممكن يكون السبب شنو؟ ها؟ أيوة.
Question again, please, Babas.
إنه زي ما قلت لك لقوا إنه if you choose cardiac CT, okay, to test for ischemia, the result you are gonna get is more informative and has more impact on future outcome than if you choose other tests.
Okay.
one reason
الكالسيوم.
دكتور حاتم.
ايوه يا ريج.
ايوه الكالسيوم عنده have a role in burden.
Okay. So,
والCT it can add to differentiate يعني vulnerable plaque, stable plaque.
very good. Very good. Very good. Thank you so much, Shari. Yeah, probably that's the cause exactly. لأنه لاحظوا يا إخواننا مثلا في الستريس إيكو. الستريس إيكو إذا في إسكيميا هتجيك بوزيتيف صح؟ اللي هو هيظهر ريجوناليتي مثلا. أو في الإسبكت هيحصل perfusion defect. Or no. So you either have yes or no. So the result is given to you in a binary fashion. There is ischemia or there is no ischemia, right? But in the cardiac CT, it's not binary. It gives you anatomy, not physiology. Anatomy, meaning if there is minor, minimal atheroma, you're going to see it. Mild atheroma, you're going to see it. Moderate atheroma, you're going to see it. Severe atheroma, you're going to see it. Total obstruction, you are going to see it. So you are going to see the entire spectrum, which you are not going to see by the physiological testing. The physiological testing, you are going to see from severe obstruction upward, not downward. Because if it is not severe enough to induce ischemia, I'm not going to pick it up in the non-invasive testing. But that's not the case in the cardiac CT. وزي ما قالت أري, you will not just have an idea about the atheroma and how obstructive, but also about the vulnerability. Yani it gives you like this, if you see these images here, it shows you the atheroma, okay, the napkin ring sign, the spotty calcification, the low attenuation, and these are all features of vulnerable plaque. Don't worry, we're going to discuss that in depth when we come to cardiac CT, okay, about the features of vulnerable plaque by cardiac CT. لكن أهم شيء إنه it gives us the entire spectrum of atheroma and how vulnerable it is. Okay. Right. Now this is a 65-year-old gentleman presented to ER with profuse oral bleeding after tooth extraction. The patient has 2 consecutive tooth extraction in a private clinic after he complains of jaw and tooth pain. He was in ER waiting for the dentist who decided X-ray and admission to secure the bleeding. And this was the ECG. Right. This question I brought just to stress on the fact that ischemic chest pain can be so atypical. And this is a real patient of mine. And I was in ER that day. And one of my colleagues approached me and showed me this ECG. Just to comment on this ECG. And he said this ECG is so gloomy. So can I see the patient? And I went bedside and I saw the patient and interviewed the patient. And then I changed the entire diagnosis.
Oh, okay. Zainab, if you want.
Yeah.
You want our comment, boss?
Uh-huh.
They see.
Yeah.
This widespread ST depression. I mean that it's more than ST depression in more than 6 weeks.
Exactly.
And ST elevation in the AVR and in the AVR more than V1.
So what does that mean?
That indicate left main.
Yes.
Yes.
Exactly. And look here, the patient, you see the history, has 2 consecutive tooth extraction after he complains of jaw and tooth pain. You know, when I went there and asked him about his tooth pain, he said, I don't have tooth pain. I have my entire jaw is aching and I have it all down here, and he points to his neck. Okay. And it is exertional. So, you know, and it was really weird history. of jaw and tooth pain. I mean ischemia expressed in this way. And surprisingly, this patient has already went to the dentist and has already had tooth extraction. You know, because ومش كده وبس, he was waiting in ER and again he was going for some dental procedure. So we took this patient to the cath lab and it was 3 vessel disease including distal left main. Okay, and went for CABG. So this is very atypical, very atypical. Okay. Now, this is a 55-year-old lady with metallic mitral valve replacement 3 years ago, presented with chest pain and shortness of breath. She had ST depression in precordial lead and her troponin is 0.2. So, what do you see here? This is the short axis, and this is the apical 4. And you see the metallic valve is here. That's the metallic valve. It looks like the first picture we have shown as a warm-up. You know, again, you are gonna see that this lateral wall is akinetic and the apex and the inferior septum. And here is towards the apex, we have severe hypokinesis, okay? What is also what is also worthy of noting is this RV. You see the RV here? RV toward the apex is what? Is hypokinetic. You can see here. Do you hear my voice? Do you hear my voice?
Yes.
Okay.
Yes.
You see the
Yes.
RV here? The RV at the base, it is contracting. When you go down toward the apex, it's not. It is hypokinetic. And this is a very, very suggestive features of Takotsubo. When you have RV apical hypokinesis, RV apical hypokinesis, okay? In myocardial infarction, you don't have that, okay? Like we said, you should always go for coronary angiogram or testing for ischemia and consider it ischemia myocardial infarction until proven otherwise. In fact, this patient was a patient of mine, and she had went to her sister. It was her sister, exactly. She went to her sister who was dying of terminal cancer, okay? Before they pulled the plug. You know, sometimes they call the family to say goodbye, and then they pull the plug and stuff like that. So she came to hospital with chest pain and shortness of breath. And we did her the echo and the ECG and troponin. We find this. So the history, along with the echo, are both suggestive of Takotsubo, stress-induced, right? Stress-induced cardiomyopathy, right?
Yes.
تمام. الحصل في البيشن دي كمان شوية غريب. I booked her for cath, and for a reason, there was traffic in cath lab that day, so they delayed her for next day. Okay? فأنا كنت طبعا I'm suspecting Takotsubo almost 99%. لكن برضو I don't have the courage, and I shouldn't have the courage to not do coronary angiogram. فقلت out of academic interest, let me do echo again before she goes to cath. Next morning, لاحظ, next morning of her presentation. And I did echo next morning on her ejection fraction. If you evaluate this ejection fraction, it's like what, 25, 30? It was 45. It was 25, so 45, less than 24 hours after her initial presentation. She started to recover. Okay, so sometimes the recovery in stress-induced cardiomyopathy is so fast. It might take few hours. Okay, few hours. Okay, وممكن يكون جانا ونحن ما حاسين وريكفرد وكده. الأحزان ما كثيرة، فما معروف غايته حصل لنا ولا ما حصل لنا. لكن نحن كان عندنا prospective study to do echo for all patients admitted to critical care and try to screen for stress-induced cardiomyopathy, okay? And we are still in the process of doing this research because we think, you know, stress-induced cardiomyopathy is much more common than what we actually diagnose, okay? عشان كده أنا بس عايزكم يا إخواننا تركزوا عليهم كثير، okay? يعني كثير في patients كثيرين are actually missed, okay? وهو كويس طبعا prognostically is fine if you support the patient the initial few days, the recovery is the rule. طيب, I'm gonna skip all of these because I'm gonna just I'm gonna skip all of these things. طيب, for arrhythmia and emergencies, atrial fibrillation is the most common type of arrhythmia you usually encounter, and VTAC is also another type you could encounter. We are not going to discuss that here today. We'll have a dedicated lecture about ECG. Okay. Now for heart failure, of course we have REF, mid-range, and BEF, and we might probably have with supernormal ejection fraction. Heart failure with supernormal ejection fraction, it might be added to the three categories here. Okay, this is when the ejection fraction is more than 65%. Okay, so HFrEF if it's less than 40, HFpEF if it's more than 50, and mid-range if it's between 41 and 49, and supernormal when it is more than 65. So HFpEF is going to be from 50 to 64. Okay, good. Now you always have to put your patient in one of these three: warm, dry, warm and wet, cold, dry, and cold and wet. Okay, warm depends on the status of the perfusion. Dry or wet depends on the status of congestion. Because if the patient, the gloomiest prognosis here, cold and wet, and the best is warm and dry. And for each one, you have a set of management protocol. Okay. Now, the level of congestion, I want you to remember, it is not all or none. The level of congestion is kind of a spectrum. So you can have careless beeline, hilar filling, which might increase to bat winging and whiting of the lungs, the cephalization, or the upper lobe diversion. So you have the stages of congestion. So when you look at the chest X-ray of a patient suspected of congestion, you have to focus on all these features: the careless beeline, the hilar filling, and the cephalization of the veins. Now for these are all causes and etiologies of heart failure. Of course, the most common cause of heart failure is ischemic, followed by valve diseases and idiopathic. But the list is so long. These are all causes of cardiomyopathies. One of the causes I want you to remember is tachycardia-induced cardiomyopathy. This is really important. We have already discussed the stress-induced cardiomyopathy. This is also another important entity which you should consider. It is tachycardiomyopathy. All type of tachycardia can induce cardiomyopathy, okay? And the issue here is once you control the fast heart rate, you are going to improve the ejection fraction, okay? لكن المشكلة اللي بتواجهك في الموضوع ده حاجة واحدة، إنه كيف تعرف إنه this is tachycardia induced cardiomyopathy؟ لأنه cardiomyopathy can be the effect and can be the result of, can be the cause and can be the effect of tachycardia. بمعنى tachycardia can be the manifestation of the cardiomyopathy or can be the cause of cardiomyopathy. فكيف تعرف الأمور؟ هنا المشكلة. فإلى حد ما برضو diagnosis is retrospective. When you control the heart rate, you find that the ejection fraction has improved dramatically over time. Okay? لكن في some sort of arrhythmia, you know, is so unlikely to accompany the cardiomyopathies and more likely to be the cause rather than the effects of cardiomyopathy. Okay. Now, the heart failure, again, we are going to discuss in depth the management protocol of heart failure, but I want you to remember this one. If patient comes with decompensation, you have to remember that this decompensation will never get patient back to his baseline. So he falls in here, and when treated and discharged home, he is here. So he is going downhill with each decompensation. That's why we should avoid decompensation by any cost. Now, what are the causes of decompensation? Ischemia, lack of adherence, salt intake, arrhythmia, myocarditis, hypertension, anemia, infection, medication like non-steroidal, thyroidal dysfunction, and renal failure and pulmonary embolism. So in the history, you have to elicit the causes of decompensation because this is important. Now, hypertension, I'm also going to skip this one for later discussion. I'm going just to take you to, what is this?
Dilated right side.
And what else?
D-shape.
Very good. D-shaped, exactly. D-shaped LV.
Yes. So most
what is
likely be pulmonary embolism, suggestive of pulmonary embolism.
Exactly. What do we see here? Look at that.
Paradoxical movement of the septum.
Paradoxical movement of the septum. Leftward shift of the septum. Dilated RV. What else? Look at the contractility of the RV in the free wall and in the apex.
It's meconium sign.
Exactly.
Sign.
So what is meconial sign?
Meconial sign is hypokinesia is a mid septum is hyperkinetic apex, RV apex.
Exactly. أو شفت أسهل من كده عشان تريح نفسك قول apical sparing hypokinesis. يبقى there is RV hypokinesis sparing the apex. So the apex is normally contracting or hypercontracting, while the RV free wall is hypokinetic. Okay. Specific sign of pulmonary embolism. Specific but not sensitive. Now, echo finding in pulmonary embolism, because this is important. I told you pulmonary embolism is one of the cardiac emergencies. It is not. لكن بيسألونا كثير ناس البلمونولوجي to do echo للpatient. مرات حتى قبل الكاردياك CT. Upon clinical suspicion, and if the patient is too sick to go to the CT scanner, they just ask us to do echo, and upon the findings in echo, they might decide to give lytic, okay? فالإيكو مهم عشان كده لازم نعرف الإيكو what does it mean in pulmonary embolism. So الآن we have seen the RV strain. This is called RV strain. Dilatation hypokinesia and apical sparing hypokinesis, okay? So we also have this 60-60 sign بمعنى إنه a TR pressure gradient is less than 60. And pulmonary acceleration time is less than 60. So it's called 60-60 sign. لاحظوا هنا a TR pressure usually is less than 60. إذا لقيته أكثر من 60 is so unlikely. Why?
Good RV function indicate
exactly. Because a TR, exactly, thank you so much. Because the TR velocity and the gradient depends on the RV systolic function. So if the RV systolic function is good, then you are expecting it مثلا تكون إذا بقت أكثر من 60 معناتها the RV function is good. لكن لأنه ال RV مع ال pulmonary embolism is so unlikely to be good and it's likely to be impaired, so unlikely to have a TR signal that leads to a gradient above 60. Okay, good. So the dilated underfilled LV, the D-shaped sign of the LV, the dilated RV with apical sparing, and the tricuspid regurgitation. And now for the ECG, I'm going to show you this one here. Sorry, ECG. Sinus tachycardia is probably the most common. مع إنه historically we stick to S1Q3 T3 because we like it, and RV strain and incomplete right bundle branch block. But remember, the most common ECG features of pulmonary embolism, if it is massive and hemodynamically significant, is sinus tachycardia. Okay. Now the question is, the following are cardiac markers. I assure you we are about to finish. The following are cardiac markers: troponin, pro-PMB, troponin C, pro-PMB, troponin T, troponin I, CA125. So say yes or no. Troponin C, yes or no? Is it a cardiac marker? Troponin C.
No.
Pro-PMB.
Yes.
Troponin T.
Yes.
Troponin I.
Yes.
CA125.
No.
No.
Okay. No. Categorically no. Which one you are so confident about?
Troponin I.
Huh?
Troponin I.
I mean, the thing that you are so confident that it is not a cardiac marker.
C125.
CA125.
Good. So now this is the troponin. We have troponin I, T, and C. So you know each one, what does it mean, and the tropin, actin, tropomyosin complex, and how the things are working and all of this, okay? Now for troponin, T and I are used as cardiac markers, but troponin C is not. Why? Why? Can anybody tell me why we are not using troponin C? لأنه نحن عايزين التروبونين. هو التروبونين ده هل موجود في السكيليتال ماسل؟ ها؟ موجود في السكيليتال ماسلز؟ Yes. هل موجود في الكاردياك ماسل؟ Of course yes. هل موجود في السموث ماسل؟ No. طيب إذا موجود في السكيليتال ماسل, how can troponin is cardiosensitive? Is cardiospecific? Is cardiospecific because troponin T and I, الايزومر بتاعهم الكاردياك ايزومر is different than the skeletal isomer. يعني troponin T and I الشكل حقهم المولكيولر biology حقهم is different than the skeletal troponin T and I. لكن C, the isomer of the heart and of the skeletal muscle is the same, so it lacks the cardiospecificity. So troponin C is out. That's why it's either T or I. You get this one?
Yes.
Good. Right. Now, I want you to remember that when we talk about troponin elevation, that does not necessarily mean myocardial infarction or ischemia. We can have cardiac and non-cardiac etiologies. Myocarditis, heart failure, myopericarditis, cardiac contusion after trauma, tachyarrhythmia, cardiovascular, CPR, cardiac surgery, and PCR. Now we have sepsis, trauma, severe renal failure, pulmonary embolism, critical illnesses, rhabdomyolysis, burn, and all of that. Now the question is, when you have an elevated troponin in a patient of sepsis, will you say that this is non-cardiac troponin?
No.
We need
how can you phrase it?
We need a rising or fall troponin to evaluate.
طيب لقيت انه في رايز وبقى steady بعد some time.
We need change 20% from the baseline.
طيب لقيت في change 20% from the baseline in a patient admitted with overwhelming sepsis, after which it becomes steady.
This indicated myocardial injury.
Thank you so much. Myocardial injury. exactly.
Yes,
يبقى
with
معناته يا اخواننا انا عايزكم بس
clinical history.
exactly. يبقى نتفق على حاجه، ما في حاجه اسمها troponin I or T non-cardiac. It is cardiac. يبقى معناته we have cardiac injury. لكن we are talking about ischemic cardiac injury versus non-ischemic cardiac injury. Okay? Or you can call it primary cardiac injury or secondary cardiac injury. يعني sepsis can induce cardiac injury through different means than ischemia. The same goes for severe renal failure and pulmonary embolism, right? يبقى ما بنقدر نقول إنه this is non-cardiac troponin. No, it is cardiac troponin, but it is non-ischemic cardiac injury. Okay, non-ischemic cardiac injury. So this is important. Now, you said CA125 is not a cardiac biomarker. I want you to change this. And it is an important cardiac marker, okay, for congestion. For congestion. طبعا CA125 stands for cancer antigen or carbohydrate antigen 125. طبعا احنا عارفين انه هو marker or tumor marker of ovarian cancer. مش كده؟
Yes.
مش كده؟ ovarian cancer. لكن it has been found انه it is an important marker of congestion for assessing congestion, guiding therapy for decongestion, and also at the therapeutic target. And it is also prognostic in terms of overall mortality and also mortality, death and heart failure hospitalization. Okay? يعني يا شباب الآن دي مسألة مهمة جدا أنا عايزكم تعرفوها. CA125 is an important cardiac marker. It's very important cardiac marker in congestion. حتى البيهيفير حقتها واللينير correlation حقها للcongestion والdecompensation in heart failure is found in so many studies to be better than PMP and pro-PMP. والprognostication حقها is also found to be better than PMP or pro-PMP, or it adds to the prognostication of PMP and pro-PMP. Okay? Tamam?
Yes, okay.
This is a brand new information. Is it?
Yes, for me, it's
Yes.
new information.
Yes, it's
Okay.
brand new.
Because just I know this that CA125 it's not specific for ovarian cancer, but it's sensitive.
Yes, exactly. Exactly. That's what we know. لكن الآن we know that now CA125 is an emerging, important, crucial cardiac marker for congestion and decompensation and mortality associated with heart failure. Okay? The last thing is the PMP, and you know also PMP increases, and this is important question in exam, what increases pro-PMP? Okay, pro-PMP, heart failure, we know, like in also acute coronary syndrome, atrial fibrillation, valves, myocarditis, cardioversion, and hypertrophy. There is non-cardiac causes, renal, pulmonary embolism, pneumonia and infection, critical illness, severe disease, cancer, chemotherapy, and all of that. It decreases in obesity. Yani obesity tends to decrease the level. That's why you have to consider the BMI in analyzing the PMP and pro-PMP. It's okay. Thank you so much. I held you longer than I expect. لكن بس عشان قلنا نعملها the first session we have to يعني. The session الأول we have to.